Yes, teacher. Under quarantine.
Okay. How about your family, Bank?
My dad's positive, but he is still okay. Today start Faripivaria already due to O8 with DM, but
Okay.
he how stable.
He stay in the hospital, right?
Yes.
Okay. Get well soon.
Thank you very much.
Get well soon.
Okay. Today we are talking about the instability. Okay. So we talk about the Bankart limb research already. Okay. And I think the BonyBankart is another story. You need to know the tricks how to deal with the BonyBankart. And another story is about the posterior instability and also the multidirectional instability. Okay, but the posterior MDI is rare comparing to the anterior instability. Okay, but you need to know how to deal with that. But I think if you have a good portal placement, you can deal with every instability. Okay, I think portal placement, patient positioning is very important. I'm not sure how about your practice in Philippines, Malaysia. You do routinely beat chair or it depends. Can you share your experience about that?
From Malaysia, we are doing instability in lateral position.
Electro, right?
Yes,
Routinely.
lateral.
Most of them or some do beat chair also.
Most of the surgeon use lateral for instability. But for rotator cuff is beach chair also.
Okay, same like us, right? Putra, same?
I don't have that much experience, but I only have seen a few cases which correct, as Tim said, for instability lateral and for rotator cuff in beach chair. In fact, even for rotator cuff, sometimes in lateral also.
Okay. About the Philippines experience?
They don't have much.
Soy and Lawrence. You should stay apart.
Yes, sir.
Sir, my professors during residency used beach chair.
Beach chair, right? For everything, Soy?
Yes, sir. Both for instability and rotator cuff.
So if you're dealing with the simple Bankart, I think beach chair is okay. But if you need to deal with the posterior instability or the multidirectional, I think it's not easy. It's not easy because you need to switch your scope to the top, and it's not easy if you put the scope and working like this, all the time. This is beach chair. You need to climb up to a chair, a stool, something like that, and you need to work like this all the time. And you need some traction from your assistant. That's not easy for them and for you too. Okay, for the posterior and NBI, I recommend you to do the TU supine position. I think you can do instability very well. Okay, Lawrence, you do in Philippines, same like Soy?
I don't have much experience, sir, based on shoulders, more on the knee. But from my professors, it depends on, because the Philippines, they don't have big institutions like Tamasat that have local fellows. So most of us train abroad. So it depends on where they're trained. So some do the lateral, but most do the beach chair.
So like man, he's from Lersin Hospital. Man in Lersin, you do all beach chair, right?
Yes, beach chair ครับอาจารย์
Beach chair in every cases, right?
Yes.
Gong is trained from Washila Hospital. How about Washila?
Almost is the beach chair position, but some for the posterior instability use the lateral position.
Okay, for some, but most of the instability they did in beach chair, right, Kong?
Yes, almost.
Kong, why you're so black?
Ah,
Huh?
I did not turn on the light.
Yeah, you look more handsome. And how about Bank? Bank?
For
Bank is
me, from Synthetic Milot, we have two position. Some surgeon use all in rotator, all in B chair, but some I think almost for instability they did with lateral DQ with
okay.
traction. ครับ
Now you know what is the benefits of the traction?
Maybe it's increase the inferior space.
You have enough space, and also your position also, I mean the surgeon position. Okay, like I say, if you do beach chair, you need to, when you switch the scope to the anterosuperior portal, you need to climb on the chair, and you're working in that position is not, it's not good for your shoulder. Okay, you fatigue and you cannot work very well. Okay, so we
Okay.
start the first case with the bony bank card. Okay, Lawrence, you ready?
Okay, sir.
Okay, let's go.
I think Sir Putra is ready for the bony bank card.
Yeah,
Okay,
I'm ready.
Putra,
So this
right?
patient is, yes, this
Putra
patient
first.
is a 49-year-old gentleman.
Uh-huh.
And his history is he had a fall directly onto the shoulder. And after that, he had a shoulder dislocation, which was reduced in another hospital. But he had persistent pain of his shoulder. So on examination, actually, he had the posterior stress test was negative. So the posterior labrum, there was clinically no instability, but anteriorly there was an instability. So the apprehension test was positive. But otherwise, the range of movement of the shoulder was good, except there was an impingement, not really impingement, but pain on forward flexion, probably because of the fracture. And other than that, his rotator cuff, there was no clinical signs of injury. So the X-ray, there are two fractures. One is at the anterior inferior glenoid, and the second is the undisplaced fracture at the greater tuberosity of the humerus. And also there's some clinical subluxation on the X-ray as well, because the AHI is actually increased.
So that is about 1 month, right, after the accident?
Yes, yes, I think 1 month.
1 month. So the patient have both GT fracture, right, and also the glenoid fracture. Can you see the glenoid fracture? Man, can you
Yes,
say from this that the patient have the bony Bankart, and how big is that?
from the film, right? In the right side of the film, there's some the anterior glenoid fragment. ครับอาจารย์
So you can see this, right? You see?
yes
It's broken, right? And if you see the sclerotic line, you see, you follow my cursor, you see that? This is anterior sclerotic line and this is posterior, okay? You see that if you draw the line and this line is disruption, okay, at the middle, you see? Here, disruption, and you cannot see the sclerotic line at the lower part. That means that's a big bone loss. It's a very big bone loss, okay? So this sclerotic line, okay? So I'm thinking about this, okay? So whenever I see the sclerotic line and it lost, okay, about half, so the percentage of bone loss is a lot, okay? But if you see this sclerotic line going down here, okay, like more than 50%, your bone loss is not too bad, okay? And also this side, you also see the big piece of bone, okay? So that's why we plan to do the CT scan. So luckily his tuberosity is not displaced. You know, if his tuberosity also displaced, this case it will be very, very difficult. Okay. So we're lucky that he came to see us for weeks. So the tuberosity going to heal, so I let it heal. Okay.
Seen.
Uh-huh.
I think
So
one more.
actually, if you have the on-face view, should be fine. You see that? That's a big piece of bone. So I
Okay.
think the bone loss is quite big for these patients. So for the portal placement,
So we are using 4 portals. The posterior portal, standard
yes,
posterior portal. Sorry, Kim's portal. We are using Kim's portal here.
yeah,
And we are using anterior, superior, anterior, inferior, and also the 5 o'clock, or in this case, because it's left side, is 7 o'clock portal.
mm-hmm.
So the anterior superior portal is just anterior to the AC joint.
Yeah,
The anterior inferior portal is just lateral to the coracoid process.
mm-hmm.
And the 7 o'clock portal is through the subscap.
To the subscap. It's just above the your axilla, right? But careful, you need to drape and safe clean your axilla. Okay. And in the back, you can see the posterior portal is here. Okay. Posterolateral portal or Kim's portal. Okay, it's different from rotator cuff. For instability, I put it more lateral. Okay. Okay, good.
Okay. Okay, so first we are going to make the Kim's portal and view, and followed by the anterior superior and anterior inferior portal.
Yeah. So look at this portal. It's if you put it the posterolateral, your portal will be parallel to the floor. Even you do the supine position. You understand? It's like this, not like this. Okay, because our portal is not in the posterior, it's a posterolateral. So your camera will not vertical like this. You understand? So you have no problem about the fluid. Okay, because you go like this. Okay, the direction like in the picture, you see that is nearly parallel to the floor. Okay, and the trick is when you put your switching stick in, do not point to the coracoid. Okay, you point it perpendicular to the glenoid. Okay, point it down, not up, not to the coracoid, because it's not the same like the routine posterior portal. Okay, but important, you need to feel the joint. Okay, I show you many times, right? You need to feel with the switching stick, not using the trocar sheet, because that's too big and you can damage the cartilage. Okay, better use the switching stick, and then you follow the switching stick with your trocar sheet. Okay, like this.
Okay. So
A lot of informations.
there's a lot of synovitis, and we are going to create the anterior inferior portal. Or in fact, in this view, we have already created it already. So I from what I remember, we used a needle and we followed up with the switching stick, and then we created the anterior inferior portal. Anterior superior portal is on the other side of the bicep tendon.
Yeah.
So
this should be in the middle. Okay. So this stick, this one you can switch front and back to the bicep, like I told you last time. Okay. Do not put it too close to the anteroinferior. Otherwise, you cannot work. It will be parallel like chopstick. You know,
okay.
we don't like to work like that. So one should be vertical like this. One will be like this. Okay. So the angle between the first one and the second one is about 70 degree, 70 or 90 degree. Okay. So you can work very well using this way. Okay. Okay, good. Next. Okay. And I use the small one, the yellow. Okay. For the, you see that there's some angulation between the portals. And now you see that
now we
there's
are
a
using
big piece of bone. Yeah.
We are using the Bankat knife now to clear the scar tissue at the anterior inferior labrum. I mean, not labrum, but the glenoid. And there is you can see that on the left-hand side here is the glenoid, on the right-hand side is the bony fragment that has been fractured from the glenoid. So what we are going to do is we are going to completely mobilize this fragment until we visualize the subscap in front of it.
Okay. So try not to use the chisel mallet. Okay. I don't like to do that. You know why? Soy, you know why I don't like to use the chisel and mallet? Soy, Lawrence.
Yes, sir. The chisel, sir, you could create create more. You cannot control it, and you can go through and create propagate the fracture further.
Yeah. So sometimes there's some you can create a new piece of bone. So try to find that BonyBankartRepair, because if you use a chisel or mallet, you can create a new fracture, and sometimes you can go in the wrong plane. So
And
try
some
to
more
use
bone loss.
some more bone loss. You use the your Bankart knife acting like the polyosteum, okay, to try to find the right way, because you can see some fibrous tissue between the bone and the BonyBankartRepair, the piece of bone, okay, and try to detach it, okay, and try
Okay.
to. Is it
So
risky
now
to the nerve, Putra? Do you think it's risky?
uh, I think as long as we don't go too medial, it should be okay.
Yeah.
I think we have to keep within about 1 to 1.5 centimeters away from the glenoid, medial to the glenoid. So we should not cross too much.
Yeah, okay. The trick is that you keep close to the bone. Like you do joint replacement, right? I do total shoulder replacement. I use the RF to release the
Mm-hmm.
soft tissue, okay, around the glenoid. No problem. You have no problem. If you keep on the bone, because the nerve is here, okay? Is you need to
Mm-hmm.
go through the capsule. You see the nerve. But if you stay on the bone, even you detach to the glenoid neck, you have no chance to injure the nerve. Okay, don't worry. Keep it close to the bone. Okay, and then slowly
Okay.
detach it until you reach 6 o'clock. So detachment mobilization is the key. If you dare not do that and you did not make a good soft tissue release, you cannot make a good bite, and you cannot go through this bone. Okay. So
Okay.
that's important, right? Detach it
Yes.
until you see the subscap.
Somehow in this video, we don't see the subcap, but by right, we should see the subcap. I think it's just the cutting of the video.
Yeah, yeah. Okay.
So next, we are cleaning up the fibrous or scar tissue.
Uh-huh.
And we want to visualize the bony fragment because it's important that we catch around or through the bony fragment when we do our repair.
Uh-huh. So this patient, if you look at this, the tie extend to the back. You see that? I show you. Go back here, you see? This tie
Yeah,
is
the tear.
extending to the back. Yeah, it's not stop at 6, you see? From this, I did detach in the back, but you see there's some detach of the labrum to the back. Okay,
Mm-hmm.
so this patient is not simple. Okay.
But in this patient, the clinical signs, there was no posterior
Yeah, right.
instability.
Yeah.
So
The
I'm
posterior,
not sure.
yeah, the posterior symptom is not that bad. Okay, but you can see there's some label tear. Okay.
So the next, we will use our spectrum to pass our shuttle suture.
Mm-hmm.
So that is coming up soon. But for now, we are still trying to visualize the subscap.
Yeah, right. Cleaning the tissues.
Mm-hmm.
See, I'm trying to do the raw surface on the uh, cartilage. You see the bone there? Yeah, that is the Bankart knife. Okay.
Okay.
Yeah,
That
you see? So now we're coming from the back, right, Putra?
Yes, because if we go from the front, the bite will not be big enough, so we have to go from the back to insert the suture. So our first suture actually starts from the bottom at approximately 6 o'clock, but slightly higher because we want to get a superior capsular shift. So our suture has to be more superior to the anchor.
So always try to catch the 6 o'clock because the piece of bone is always like this. Okay, so you try to catch the 6 o'clock, you can catch some part of the tip of the bone, okay, and lift it up like that. Okay.
So once we have passed this, we can actually put in the first anchor. And okay, so this is the PDS suture has been passed. And oh yeah, we are creating the 7 o'clock portal because we haven't, or the 5 o'clock portal because we haven't done that yet.
Right. So this portal also have to be as far as possible from the glenoid. Okay. So you can make a good bite. Okay. Using the needle to find the location, and then I will not put the cannula on this. Okay, most of the time. Okay. So after you get that, put the small switching stick in. You see that? It's very close to the bone. You need to go through the subscapularis like that. See?
Okay.
And make sure that you can go straight.
So the aim to make this portal actually is to be able to easily access the 6 o'clock position. So the needle should be, when you pass the needle, you should be able to access that. That's when you know you're in the right place. So after creating,
Okay, then do the dilatations. Okay, dilate.
Okay.
But if the patient have a very big size shoulder, you can put the cannula in. But most of the time, if you have portal jam with the antro-inferior, okay, the one that just above the subscap. So most of the time, I use the half pipe, okay, to keep this track.
Okay.
This one, what did we use? We used a half pipe, right?
I think we put in a cannula, if I'm not
cannula,
mistaken.
Right?
I think so. Oh, no, we put a half pipe for this.
Half pipe, we put half pipe,
half
right?
pipe.
Good. And then we can put the better, you see that the position of the anchor is very nice using this one. You can go very low, right?
So the anchor should be positioned higher than the suture so that when you tie the knot, it will have a superior shift of the repair capsule and the repair of the Bankart lesion. So the placement of the anchor should be not on the side but on the rim of the glenoid, at least 1 to 2 mm on the glenoid surface. So in this case, we have used, if I'm not mistaken, it's a Y knot anchor. And we are removing all the other sutures to the posterior portal just for suture management.
Actually, this is not Y knot. It is the suture fix.
Suture fix.
Suture fix. It's same like Y knot. And this from the Smith Nephews.
Okay.
Yeah.
It's a Q fix, is it?
No, suture fix. The name is suture fix. Smaller.
Okay.
You see the piece of bone?
Yes.
How about the percentage? You see? It's so big. See? I think that this is nearly half of the glenoid. You see that? Very big. And someone prefer to put the screw in if they have the big size like this. Okay? But I think nowadays the suture anchor fixation also very good if you can do a good job. Okay? But this is controversy. Someone put the screw for this kind of fracture. Okay.
Okay.
But I will try to use this suture anchor fixation first. You see that this is a half pipe, right? Then
so next we are going to put in another a spectrum to put in another suture in the around the Bankart, around the BonyBankart piece. So again, we are going from posterior to catch around the fragment.
No, this is anterior, Putra.
Yes, we are going from
This
anterior.
is anterior. But you see that I try to catch the triangular shape because the piece of bone is always like this, right? It's big in the middle. It's small on the top and the lower part, right? So now you try to catch the smallest part. Okay, it's like a small corner. Catch is allow this bone together. But this is will not too difficult for this stage. But the most difficult stage is in the middle part because you need to hook around the piece of bone, you know. Not go through the bone, you always go around the bone. Okay? Like that. Okay?
So this is going from anterior because we are catching the corner. Okay.
Yeah, catching the corner, right? Very good. The labrum together with the corner. Okay? This is the important that you need to mobilize the bone freely. Otherwise, you cannot find the tip of the needle. Okay, I think this is the most difficult step for you. Okay.
Even in this case, we don't really see the tip of the needle, but the suture comes to the front, so we can see that.
Okay, you see that? You see the suture running? Yeah. Okay. Yeah. So another trick is that when you go through the bone, try not to go into the bone, you know. You should go around. If you try to go into the bone, the problem is that the bone dust will be in the tip of the needle. You know, the bone dust, it will obstruct the tip of the needle and you cannot throw the suture into the joint. Okay, try to go around. Do not put it into the bone. Okay, otherwise you cannot make this this shuttle suture will not work. Okay,
even if you use the metal,
okay, the metal will be better because metal you can push the bone dust away. Okay, like that.
After this, I think you use the metal one for the
right
for the
next
for
one.
the center.
You see the subscap? This is important. You see that here? You see? You need to see this because in this step, the next one is most difficult because you need to go to the biggest part of the bone. So when you pass the suture in, you will see your suture here. Okay? This is important. Otherwise, you cannot retrieve it. So, someone try to go through the bone. Like Sukaya, he used the he calling it's the BonyBankart stitch. He go through the bone. Okay, he used a very sharp, but inside is a metal. Okay, but we didn't have that one. Okay, you see that here.
Yeah, okay? So the metal is coming,
and that's a metal, right? You see the tip is a metal. So you need to use a Bankart knife, okay, to retract the piece of bone away. Then you can see the metal. See that? That's a metal. That's a different one. It's not spectrum. This is the another suture hook from MyTech. This is from MyTech.
Okay.
And the curve is nearly straight. Okay, it's nearly straight. You see that? From here,
like
this is the biggest part, right? The thickest part. So the way to do that is not hook around. It's not like that. You go through like this. Go through. Okay. Go through until the tip of the needle is go underneath the bone. Okay. And find the tip of the needle by retracting the piece of bone away. like I show you.
The Bankart knife.
Yeah,
Okay.
Bankart knife. Retract it away, then you see the tip of the needle, then you retrieve the suture up. Okay. Okay, next.
Okay. So I think next we are going to put another anchor already. We are using a double loaded anchor, right, Dr. Bancha?
Yeah, always.
For double loaded. Okay.
You know the ply is the same. The ply is
Triple
the
and
same. You can have double fixation, but if you single, the price is the same. So I
okay.
prefer using double. Okay.
Okay.
Then
So
the
now we are
next
going to
one.
insert the second anchor.
Yeah.
So the
Try
procedure
to
is the
go
same.
on the
Only thing
surface. But this
now we
one,
are
you
not
see that
coming.
I try not to make a trough. You see? You know why?
Because it will create more bone loss.
Yeah, because this is not on the edge of the glenoid. And you don't want the soft tissue to heal on this. You want bone to bone healing, right? Okay. So you don't need to create a trough because you create the cartilage injury in the middle of the glenoid. It's different from the Bankart, right? It's on the edge of the glenoid. But this bone trough will be in the middle of the glenoid. Okay?
Understand.
Got it?
So just now we were using the 5 o'clock portal to insert the anchor. Now we are using the anterior inferior portal to put in this anchor. So the position is actually at the 3 o'clock, or actually in this case 9 o'clock, I think. Oh yeah, this is me and nephew. Yeah.
Yeah. Double load again.
So after this, we'll start by time the bottom from 6 o'clock. So this we are tying from the posterior portal. And then we will work our way tying up. We'll move the suture tying to the anterior as we move superiorly.
Yeah. So the first stitch always come from the back. Okay.
That's because it's easier to approach from the back, right, Dr. Bancha?
Right. Because
There's
it's
no
very,
head.
very low. You cannot tie it from the front. Okay.
Okay. So this now is tying from the front.
So man, you see some stepping here, right, man?
Yes, I see.
It's not good, right?
I think now is not smooth.
It's not smooth. You worry about that?
I'm not sure.
You're not sure, but yeah.
I think it will remodeling.
Don't worry about that because when you release the traction, the head will mold. Okay, will mold this, and finally it will be flat. Okay, don't worry because when you release the traction, it's never stepping like this because you're afraid of this piece dropping down, right? It's always dropping down. Okay, when you release the traction and the head will more on the glenoid. Okay, so don't worry about this. So someone try to do the double fixations. I think that's you invest too much. Okay, I'm happy with this technique, and I did the CT scan after the surgery. I found that the bony healing is perfect and also it's always flat. Okay, nice healing. So don't worry about that.
Okay.
Yeah, even it's like this stepping. Because this is like the you see that the piece of bone still can move. Okay, because you just fix it with the soft tissue, right? It's different if you put it with the bone, with the screw. It cannot. it fixed and it cannot move. But this suture, this piece of bone can move a little bit. And it's good if you have the bone like this, okay? You see? If you tie it like this, you see? It's like this. So finally it will be here like this.
Because of molding.
Yeah, molding.
Okay.
Yeah. See that? So that's the last stitch. At 3 o'clock, right? Subscap is about 3 o'clock.
Yes. Do we need to catch the corner on the superior part also, Dr. Bancha? Or
Right.
only down?
Right. Same way. Same way.
Same. Okay. So this is the superior suture, and after this we will repair the posterior labral tear.
Yeah. Okay.
Okay. So while we are waiting, I think maybe I will just talk about the rehabilitation post-operatively. We need to immobilize, not immobilize, but we limit the external rotation to 0 degrees. We do not want to external rotate more than a neutral position for the first 4 to 6 weeks.
Yeah. For the instability, don't worry about the post-op stiffness because it's very rare that patient would have the stiffness after surgery. Okay. So your concern is the dislocation, not the stiffness. Okay. So for the rehab for instability, actually I have no concern about that. Okay. So we limit the rotations about 10 degree per week. Okay. So after the fixation is the nice, pretty stable. Okay. Then we switch a camera to the top. Okay. And this healing is pretty very fast for the BonyBankartRepair.
BonyBankartRepair.
Yeah, very fast.
Because of the bone-to-bone
right.
Healing.
This patient, the recovery also very, very nice. You remember?
Yes, this patient was in March.
Yeah, in March. Lawrence, you may share the results to the group after this. Yes, fine. Here's the last follow-up. Because in the video, I think you didn't have the last follow-up, right? So now we switch your camera from the posterior, right, to the
from the anterior superior, I think.
Yeah, right.
View.
Okay.
And we are probing the posterior tear. So now we are going to do a labral repair here. So again, we are going to pass the shuttle suture first, and then put in the anchor slightly superior to it, so there can be a capsular shift, and then we will tie one stitch here.
Yeah.
But
so
I saw
the
that
important one is the inferior. If you want to secure, right, you can go from this. You can do some more capsular shift. Okay. So shift it and repairing the postural inferior. I think that's an important part. But I think his symptom is he has no symptom on the posterior instability, right, from the pre-op examinations.
Right. So I'm not sure how come we use the metal, but maybe it was just available.
It's the straight one.
Okay.
Yeah, because if you very close to the labrum, the straight one is fine.
Okay.
We use a suture hook if that state is far from your portal. Okay. But if that state is just in front of your portal, like this, okay, you use the straight one. Like you do the slab repair also, I use the straight one. Okay.
Okay.
But careful your anchor here. You remember that your anchor first one is it here, right? Very close. So your anchor should be very careful because you're coming conversion, right?
Okay.
If you drill in and you hit the anchor, this suture will be loose or rupture. Okay, so very careful.
Okay.
If you put it very close, because this is front and back, you can damage your anchor. Very careful. So
In
I
this case,
try.
how would you avoid hitting the anterior anchor? Would you direct the drill more towards the medial side so
Right.
that it
I
won't?
try to put it higher. Put it
Okay.
higher, right? You be safe.
Okay. I think.
I have this happen for 2 times. Okay, very sad because you lost the anchor and
Do
you
it
need to
again.
do it again, right? You see that I try to go it a bit far because I want to shift the tissue superiorly. You see that? If you put it here, here, you see, it's very close and it will conversion. Okay, I try to avoid that, so I put this anchor a bit higher, right?
Okay.
My goal is to shift the inferior capsule superiorly,
Okay.
front and back. You see, our repair is always lower than our anchor. Okay, keep in mind. Another one, yes. So this
So
two stitch, I think this two is enough, and we can do two double load, right? You get 2 bite. Okay,
Okay.
but I think that's good enough.
I think we cut. Did we tie it? Oh, we tie it there. Okay.
Yeah.
But we didn't pass the. We didn't pass the
Spectrum,
what we
right?
call shuttle suture.
Uh-huh.
We only passed the shuttle suture once. How did we tie?
It's the
Maybe
edit.
What, Lawrence?
It passed the shuttle twice. I just
Oh,
Twice.
okay.
I showed it once.
Oh, Lawrence show one, but
Like
actually we passed it twice.
yes, it's a artistic choice.
Yeah.
Okay. So that's a complete repair, anterior and posterior.
Uh-huh.
So you can see the bony Bankart lesion is quite stable and not displacing.
Uh-huh.
And even the stepping is, I think, a bit reduced now, although compared to previous view.
Uh-huh. Right. Okay. Should be good. So actually we have the CT scan of these patients. This is the post-op day 1, right? We let the patient move his elbow and hand, and we maximize limit the motion at 0 degree. Okay, at first week.
Okay, so this is the follow-up X-rays.
Yeah.
The patient, as you can see, there's
Uh-huh.
the sclerotic line is congruent in
Yeah.
the Gaussian view,
Yeah. Okay. Okay.
and
Really nice.
this is the
His
range of
motions.
motion of the patient is already at the full with some limitation on the I think some internal rotation.
How long was that? In 2010?
This one is the latest around June.
This is, I think, 2.5
June.
months.
2.5, right?
It's
So
only
his recovery is very fast. Okay,
2 months. It's 2
faster
months.
than I expect, right? This is 2 months only,
Mhm.
right?
Yes, sir. This is 2 months.
This is 1st of June. The operation was 27 March. So yeah, 2 months.
Yeah. So even external rotations is pretty good. Okay. So I think we did the CT scan for him. So please add his CT scan Kong into the folder, okay? Because this is a nice case, and if you have the complete from the beginning to the end with the result and the CT scan, you see the whole story, okay? From the
Noted,
beginning
sir.
to the end. Okay. Thank you, Putra and Lawrence. So stop
Thank you,
sharing.
Dr. Bancha.
Yeah.